This is my typical consent for labor. Period. Initially, I come to the bedside, examine a patient, and evaluate where a patient might be. After that evaluation, I provide the options to every patient in similar fashion, what's appropriate and not appropriate, period. So option one is always to do nothing. And I say that tongue-in-cheek because we're clearly not here to do nothing. We're here to have a baby, to do something. But do nothing is still an option. You can stay here in this hospital for the next week, and I promise you'll have your baby. You'll eventually go into labor. You'll eventually deliver. But we could do nothing. We have you in a safe place. That's really where I want you to be, and you're in control. But in truth, at any point in time that we're doing a bunch of things, we can always stop, we can slow down, and we can do nothing. And that's why I mentioned that. Do nothing. Option two, side attack. What I like about side attack is that it works. What I don't like about side attack is that it works. What that means to you and to me is that whenever I give it to you, I can't take it away. If your baby likes it or doesn't like it, or you don't like it, we're kind of stuck with that. And we've got to work through that process. And it's dosed about every 4 hours. So it takes about some time for us to get through that. Side attack is given bulkily or given vaginally. So that could mean a lot of exams every 4 hours. In our hospital, we're able to do intermittent monitoring with side attack as long as baby's happy. You can eat with side attack and get up and move around with side attack. The negative of side attack is just the multiple exams, and it's dosed every 4 hours, and can sometimes be a protracted event. Next option is Cervidil. Cervidil is a cousin of side attack. It's a prostaglandin. It goes next to the cervix. What we like about this Cervidil is it's a little bit gentler than that of the side attack. We can place it and it stays there for 12 long hours. We don't have to come back for multiple exams. We like the Cervidil because it's actually on a tampon-like string and we can actually pull it out. What we don't like about Cervidil is it's similar to that of the side attack. Once we give it, even though we can pull it out, we really can't pull it out completely, right? It's like the hot baked potato. You reach in the oven, grab a hot baked potato, burns your hand. You drop that hot baked potato, what's happening to your hand? It's still burning, correct? So we still have to adjust and make changes if baby doesn't tolerate it very well, or if we need to do some things to help you through that labor process with the Cervidil. But it is a good medicine. It's a safe medicine. It's one that we use frequently in special circumstances. Period. Next option is Pitocin. Now, Pitocin is the one that has all the bad rep in the community, but I like to express to everyone that I think it's one of the best medications in the hospital. I tell everyone I will fight the general surgeon or the cardiothoracic surgeon. I will fight the neurosurgeon to tell them my medicine is just as good as theirs. What am I saying? They use a medication called TPA. TPA is a clot buster. If you were to push this medicine in the IV when someone has an acute stroke or heart attack, it saves lives, it saves brains, it saves hearts, right? Because it breaks up that clot that's caused the problem. So Pitocin is just as good. Why are you saying, Doc, it's just as good? Because probably 80% of the moms on our unit experience Pitocin in their labor. Another 80%, 90 plus, have great outcomes, no problems, no issues. A small percentage has questionable issues, and even smaller percentage blames it on the Pitocin. And even a smaller percentage takes the time to write the blogs that we read that says the Pitocin is a bad medication. Pitocin's half-life is 6 minutes. That's why it's a good medicine. Pitocin can be stopped very easily. And more importantly, because you, the patient, have control. The problem I think people have with Pitocin is that most of us write the same order, start at low dose and go to a higher dose. And the provider knows that it's supposed to be increased about every 30 minutes. And the provider calls in and speaks to the nurse and says, it's been 3 hours and it should be at X dose. And the nurse says it's not. We can understand that that becomes a very challenging circumstance for the nurse and provider. And I don't ever practice like that. Remember, as I've stated before, you're the boss. No one should do anything to you, as we call that assault, right? So every time the provider walks into the room or the nurse walks into the room, they should always ask, where are you? How are you feeling? It's time to turn up. Can we turn up? May we turn up? At any point in time, you can ask for it to be turned off. You can ask for it to stay at a certain level. Our job isn't to force this upon you. Our job is to help you through this safely. Keep you, your baby, your family safe. We have to be smart about Pitocin, though. It does have some negative side effects, right? It's like going to the gym and you pick up a 100-pound weight and you do 100 curls. You put that 100-pound weight down. And then you grab a 20-pound weight. What does it feel like? It feels like 100 pounds. Why? Because the muscle gets fatigued. Well, Pitocin is the only medicine that acts directly on the uterine muscle, the Pitocin receptors on the uterine muscle. And therefore, extended use, long use, unregulated use can cause muscle fatigue, increased risk of postpartum hemorrhage. Can also affect the effectiveness of the Pitocin on the uterus to cause adequate contractions. So we do have to be smart about how we use it so that we use it safely. In my care, I typically do 3 sets, go up to our max dose, take a break, go up to our max dose again, take a break, and a third time. In general, I can get most all patients into active labor without any other additional cares or needs. Well, doc, are there any other options? Patients will ask me, other than these types of medications to help you go into labor. Well, we can try a balloon. A Cook's or Foley catheter goes into the cervix, puts traction on the cervix, uses the body's own natural prostaglandins. What I like about that is that when it comes out, you'll be manually dilated to 4 to 6 centimeters dilated, depending on which modality you use. What I don't like about it is it's intense. It's intense enough that it pushes some patients directly to an epidural. Most patients tolerate it well, don't need an epidural, but it could. The negative of it is that even though we use this modality and it comes out and you're advancedly dilated, it doesn't mean you're in labor. We may still need to use Pitocin or Cytotec or some other contraction agent to get you into active labor. But it's a good choice nonetheless. Other options might be more natural type stuff. Getting out, moving around, mild circuit, birth ball, breast pump, all these things. In my professional career, I don't think I've seen more than 2 or 3 people push hard enough and do enough in a short window of time to get themselves into active labor. But you can still try those things. Next, I'd like to talk about the airplane ride. We're about ready to go on an airplane ride. Our journey here. And on this airplane ride, I get to be 2 people. First, flight attendant, and I just did my job there, standing in the middle of the aisle, showing you the exit signs, all the safety features and everything on this flight, right? And on this flight, I also have to tell you, we could hit turbulence. We see our turbulence on the monitor as we're looking at the screen here. Baby's heartbeat goes down, and a sea of blue or green or whatnot, our nurses will come in to turn you, rotate you, flip you, put oxygen on you to help you get through this flight. Just like the airplane, right? The oxygen mask may fall down from the sky. You're going to put that oxygen on you first, not me. Just like on the airplane, if there was turbulence, the seatbelt sign comes on. Well, you have your seatbelt on right now, your fetal monitors. Keep them on. We need to know that you and your baby are safe throughout this flight. And just like on the airplane as well, whenever there's turbulence, the captain always speaks up. Now I get to be the captain. I'm the captain. Whether I'm standing in front of you or if I'm in the call room or other, the nurses are always speaking with me and know that I'm always flying this flight. Flying the plane. I'm still flying the plane. Now, what we don't tell you is that there's 2 times we're most likely to hit turbulence. One is when we take off. The other is when we land. Landing a plane is not a big deal in general. Heart tones go down. We come check. You're complete. It's time to push. Push, and let's land the plane. Sometimes when we're trying to land the plane, the heart tones stay down for some time and they're not moving correctly, and we're right there at that point. We have options. Those options sometimes look like an emergency landing. That might be a vacuum-assisted or a forceps-assisted delivery. Sometimes the right answer is to transition to an urgent C-section. The other time we hit turbulence is when we take off. Taking off and hitting turbulence makes us a lot more nervous. Why is that? Because we don't know where we're flying to. If this is our first baby, we could be flying to San Francisco from Phoenix. That's 45 minutes, and we're hitting turbulence. We just push through and land in San Francisco. But if we're flying to Japan from Phoenix, that could be 14, 16, 18 hours from now. And that's a long flight to be hitting turbulence. In those types of flights, we would want to definitely transition, detour for a safe landing.